Mark. Really looking forward to hearing you this morning. Would you please welcome Mark Whitbread.
Good morning. Firstly, thank you for inviting me to speak at your conference. I wasn't sure what present to bring to Australia it's my first visit, so I decided to bring the weather. And also, just to reassure you, I'm not going to take my clothes off. You wouldn't want to see that either. So I've been asked to give an overview of the UK, and I'm going to do that hopefully, and also give you a little bit of taste of what goes on in London to give you an idea. We support the Academy and what they do, and we've been collecting data for years in London, for over 10 years in a registry format, so hopefully I can share some of that with you. I've put a statement here about we don't take patients to hospital to have cardiac arrest, and I think that's very important. I've been in the National Health Service for just coming up to 35 years, and I spent the first part working in a hospital structure, teaching resuscitation to all grades of staff, and then I moved into the ambulance service about 20 years ago. And it wasn't until I moved into the ambulance service that I realised that actually this is where the cardiac arrests are occurring on a daily basis. So in an average hospital, a district hospital in the UK, they might see perhaps 200-300 cardiac arrests a year. In London, we're seeing over 10,000 a year out of hospital. So from my point of view, cardiac arrest is a pre-hospital disease that we need to address. And I think that's very important. And perhaps some of the things I'm going to say may be a little bit controversial. I hope they're not too controversial, but I think it's important that those involved in out-of-hospital resuscitation take on the duty to improve survival, and that's what the Academy and the Alliance and everything else is geared towards doing. So hopefully I will get that message across as we go along. Of course, there is this perception amongst some of the medical profession around the world that if you have an out-of-hospital cardiac arrest, you die. And we've already heard of survival rates being poor. And this is roughly what 7% survival will look like. So when we talk about survival rates being approximately 10%, that's really an appalling figure. And we have to do something about that. And that's why we're all here today, and that's why we have the various academies. Of course, if you were to be an avid TV person, you would get a very different story. This is back in the mid-90s where some very sad people decided to watch all the episodes of ER and Chicago Hope and 30 episodes of Rescue 911 to work out cardiac arrest survival. And of course they showed that all the cardiac arrests were in children and teenagers, and we know that's not the case. And they all survived nearly, and it was absolutely fantastic. So unfortunately, the media will often present to us a completely different picture to what we face on a daily basis. And that's not helpful either. We have a program in the UK called Casualty. That's the old-fashioned term for ER, or the emergency department. And even on those programs, you know, you get this horrific crash and everyone survives, and you get all these cardiac arrests and everyone survives. And it's really a very, very false picture, but some people like to promote all that. So as I said to you, cardiac arrest is ultimately an EMS disease, and we know that there is a time limit. We can change that time from a survival, as you all know, by introducing public access defibrillation, community CPR, and also an appropriate ambulance response. So we can change that curve. And if you think of the 10 steps, and if you think of the role of the Academy in promoting how we manage cardiac arrest, it's to alter this curve. It's to improve survival. But we are talking about crucial minutes. We are talking about crucial minutes, and that's an important message to get across. Yes, we have guidelines. We have tons of guidelines, and this is perhaps where I might be a little bit controversial, so I will apologise in advance if I upset anybody in the audience. Guidelines are written by experts. A lot of them are quite senior. And generally the guidelines are written for in-hospital cardiac arrest. They're not written for out-of-hospital cardiac arrest. What I mean by that is if you flick through some guideline manuals, it won't tell you how to remove someone from the bedroom upstairs to the back of the truck downstairs. It won't tell you how to do that. It generally won't tell you as a paramedic how to manage someone with a falling blood pressure and a reducing cardiac output upstairs before you get them downstairs. And when I say to some people, well, what do I do for a patient who remains in ventricular fibrillation despite X number of shocks, the message back is often, take them to hospital. And that's true, but how are we going to get them to hospital in a viable state for the resuscitation to continue and to achieve a positive outcome? So I think it's very important that when we look at guidelines as ambulance services globally, we adjust the guidelines appropriately for the ambulance services in which we work in, because the way we work in London is going to be very difficult to how we would work in rural Australia. And I would have no idea how to manage a cardiac arrest in rural Australia. So I think it's important that we use guidelines, so please don't feel that I'm against guidelines, because I'm not. But I do think that we have to look at guidelines carefully, and we have to see how those guidelines fit into the way we operate as an EMS system. And I think that's important. Mickey Eisenberg, one of the fathers of resuscitation, you've already heard his name, and is instrumental in developing the Seattle system, and you're going to hear a lot about the Seattle system. It is a unique system, and there's no reason why we can't adopt the points and the bits of Seattle that you can bring to your system. They often say about Seattle, it's the best place in the world to have a cardiac arrest. It is considered the worst place in the world to faint. So in an editorial in Resuscitation, Mickey Eisenberg said that it takes a system, and you've heard that, and you will continue to hear that, because it is a system. If you want to improve survival from cardiac arrest, you must have a system. There is no one element. And interestingly, if you have the right system to manage cardiac arrest, you usually end up with a very high-performing ambulance service. Because if you can drive up survival, one of the elements, for example, is getting to patients quickly. So that drives up, by default, performance. So a system that has a good, high survival rate often is a very good general EMS system. And that's something to remember. Of course, there is no silver bullet. There is no special syringe that we can inject to improve survival. People come up with various elements, and it has to all be brought together. So as the 10 steps I've already said, it's about bringing those 10 steps together to resuscitate the patient. There's no secret formula that you introduce one thing that will change survival, and that's important to remember. When people talk about survival, they talk about 35% we saw for Victoria, 31% in my own service, etc., etc. That's generally talking about ventricular fibrillation. So those that should stand a reasonable chance of survival. So it's very important that when we talk about survival, when we quote figures, we are measuring apples against apples and not apples against oranges, because you will then end up with a completely different picture. So I would say to you that when you talk about survival, be very clear about what you're measuring. And most people will measure outcome from ventricular fibrillation, because if all the elements are in place, this is the group that should do the best. And I'll come back to that shortly. And as I've already said, systems with high survival from ventricular fibrillation are often very, very good EMS systems. This is what 30% looks like. A big difference. I think in a modern EMS system anywhere in the developed world, it is not unreasonable to expect a 30+% survival rate from ventricular fibrillation. It should be 40%, it should be 50%, but we have to start somewhere. But there is a big difference from 10% and 30%. So we have to move forward to improve survival from cardiac arrest. Back in 2014 in the British Medical Journal, there was an editorial where one senior UK doctor said that we should let ambulance crews, I don't know what it's like in Australia, but that term infuriates paramedics when we say ambulance crews. But this doctor said that ambulance crews should deliver the best possible care and argues that we shouldn't be taking cardiac arrests to hospital. And in the same editorial, there was a senior US doctor that warned, be a bit careful about what you do with that statement, i.e. about not taking people to hospital that are in cardiac arrest. And I'll come back to that later on. So on to the national picture in the UK and what's going on, just to give you a flavour, and then I'll switch a little bit to what goes on in London. So the incidence of cardiac arrest in the UK is 53 per 100,000. You can see 1 to 10 along the bottom because we have 10 ambulance services in the UK. We used to have 33 ambulance services, but with amalgamation they brought it together so that we now have 10. So we know the incidence of cardiac arrest, and that's an average figure that you will see in a developed country. So 53 cardiac arrests per 100,000 population. From an ambulance service point of view, of course, it only makes up a tiny percentage of the emergency calls. So we put a lot of resources into a small number of patients, but a very important number of patients. And that's the message there. So we know that in the UK there are about 60,000 out-of-hospital cardiac arrests a year, and resuscitation is attempted, as you can see, approaching 50% of those. And that would be consistent in London. It's just over 10,000 cardiac arrests we attend, but we attempt resuscitation on roughly half of those, i.e. the other 50% are beyond help. There is not a lot we can do. And the overall ROSC is 25%, and the overall survival is 7.8%. And that will be consistent with the messages that you've heard already. Notice it doesn't say what the ROSC is for ventricular fibrillation and what the survival is for ventricular fibrillation. So the minute you add everything together, you're going to skew the figures slightly. So be very careful. So this is for all comers. So the trauma, the overdoses, the suicides, and of course the cardiac causes of cardiac arrest. There's no surprise about the etiology of what causes the cardiac arrest. The number one cause is going to be cardiac, either an acute arrhythmic disturbance or an acute ischemic event, and then you have the trauma, the drowning, etc., etc. So it's important to know the etiology of how you collect. The ambulance services in the UK submit all their data monthly. We have to submit cardiac arrest data to government, and they publish those figures each month. So of all the 10 ambulance services, we can each see each other's figures, and I'll show you some of those figures shortly. And that is a requirement of the ambulance service. You do not have a choice. You have to submit your figures monthly. And then we also, in the UK, submit data to the University of Warwick, compiling a huge registry of data for the UK, and that's how I can tell you some of these figures, because that's from the University of Warwick's registry for which ambulance service submit data. So the major cause of cardiac arrest is cardiac, which is not a surprise. One of the hospitals I work with in London, one of the big university teaching hospitals, King's College Hospital in South London, recently done a 6-month audit of patients who had suffered a cardiac arrest, received resuscitation quickly, achieved ROSC, and it was believed that on their ROSC ECG, they were having an acute ST elevation myocardial infarction, an acute heart attack, and therefore were taken to one of our cardiac centres, and I'll tell you more about the cardiac centres shortly. But interestingly, when you look at the patients, the cause of the cardiac arrests are vast, absolutely vast. And that's an important message. So when you're setting up a system to take patients to hospital, it's important to understand that we often assume they're all cardiac, but when you start to break down the actual causes, some of them are not. Now, listed here, of course, are a lot of cardiac causes, but the actual number of STEMIs is, as you can see, 44, so it's not many. And there's one interesting case which I'll just touch on, and this was an elderly chap who was out celebrating his birthday with his family, with his sons and daughters and grandchildren. When he started to feel unwell in the restaurant, he started to cough, and that was the clue. He collapsed, and on the arrival of EMS was in ventricular fibrillation. He underwent resuscitation, he was cardioverted out of ventricular fibrillation and achieved ROSC. The 12-lead ECG that was recorded was slightly abnormal, and it was believed that this might be an ST elevation myocardial infarction, so a decision was made to take him to one of our heart attack centres, so where he could be assessed by a cardiologist, have an angiogram, and hopefully have the blocked coronary artery opened and everything would be hunky-dory. So off he went to the cardiac cath lab. He underwent angiography, as you can see. They noticed where the red arrow is that there was something odd on the angiogram which they couldn't work out. Where you see the yellow arrows, they couldn't work out what that was. So they decided to put a bronchoscope in and remove his false teeth. His coronary arteries were essentially normal. And so it was put down that the cardiac arrest was caused to an hypoxic event due to swallowing his false teeth. So not all cardiac arrests appear what they appear to be. So it is different. It is different. There's no surprise about where cardiac arrests occur. This is very common in all systems. The majority of cardiac arrests occur in the home. Now, if I was being really cynical, I could say to you, we spend dollars, as has been mentioned, where to spend your money. We spend dollars putting defibs into public places. We spend countless hours training school children and clubs to do CPR. But the majority of cardiac arrests are at home, and school children should be at school. So there is a slight confusion here. But we do know that the majority of cardiac arrests do occur in the home, and you could argue, should you have a defibrillator in the home? The Frank Pantridge model from Belfast of having a defibrillator next to your home fire extinguisher. So have a home defibrillator that perhaps you could buy from the local supermarket for $200, and it will give 3 shocks and then turn off, and that'll be it. I don't know, but we do know that the majority of cardiac arrests occur in the home. Witnessed versus non-witnessed, this is national data, as you can see. It varies considerably where you go. So during the day in London, for example, we have a high percentage of cardiac arrests witnessed because there's a lot of people around. So once again, there's no big shock here when you look at the data. Bystander CPR, this is the national picture in London, in England, I beg your pardon, and you can see that we're getting better at teaching CPR to everybody, and bystander CPR is being undertaken. But we've got a long way to go when you compare us, for example, to Norway, and of course you've heard, and we'll hear after tea, about Seattle. Norway, they teach it in the schools. In the UK, we've tried to get it into the curriculum, the school curriculum, and it just goes nowhere. And you can go and see the Prime Minister, depending on who it is today, but you can go and see the Prime Minister and try and persuade them. You can meet with everybody, and everyone is very supportive of it, but it doesn't happen. But clearly, there is still work to be done. Public access defibrillation. So, for example, in London alone, we have just over 4,000 AEDs in public locations. We have one railway station in London, which is known as London Bridge, that has had 7 cardiac arrests and 7 survivors. And the fascinating thing about that statistic, the same member of railway staff was on duty for all 7 and defibrillated all 7. So when the commuters now ask for his rota, so they know where to go. But it's just interesting that if you keep a registry, you can start to plot all this data. But this is national data from the UK, and this is appalling. This is appalling. So this is public access defibrillation was only used 2.4% of the time. That's appalling. We have parts of the UK where the AEDs are in public locations, but they're in locked cabinets. Work that one out. Okay, so you have to dial 999 and ask them for the code, and they will then give you the code so you can unlock the cabinet. Yeah, I'm not sure that's the way to do it, and it's not something I would support. But it's really interesting that we put defibrillators into public places, but the usage is very, very low. So there is a lot of work to do about where you put your public access defibrillators and how you're going to access them and are they going to be used. This is London data Pacific. We have a high rate of bystander CPR, just over 62% of cardiac arrests, and this is data from our public access defibrillation. So this is 2 years old data, so I apologise for that, where there's 88 patients that were accessed by a public access defibrillator. ROSC, almost 74%, and survival approaching 60%. So when public access defibrillation works, it works very well. What we need to do is increase the usage. That's what we need to do. And we do that in London via various ways. So, for example, the Beefeater is at the Tower of London. Very high profile, very high profile. And some of you may recognise the woman doing CPR on a mannequin. That's Helen Mirren. We try and get celebrities to promote it. There is a reason why Helen's involved in our campaign, which I won't go into, but she does have someone who has suffered a sudden cardiac arrest and survived. So where we can, we use high-profile figures to promote defibrillators in public places and learning CPR, and that's important. So where it does work, it works very well. What we need to see nationally and internationally is an increase in its usage, and that's important. This is, once again, back to the national picture. This is about survival versus time of arrival. There's no surprise there that the longer you take EMS to get to your patient in VF, the lower the survival, unless you can have high-quality CPR started very quickly and an AED applied very quickly. So there is a correlation with time, which is no surprise to you. Very recently in the UK, it was agreed that we would implement new response targets. They're still being all worked out for everyone to adopt. But just so you know, the current standard in the UK is that 75% of red ones, a red one in the UK is actually a cardiac arrest, so 75% of cardiac arrests have to be responded to within 8 minutes. I'm not a politician, and I don't agree with all that concept of performance, but it's important for some people. I don't know how you identify the 75% that get it in 8 minutes, because what about the other 25%? It's okay not to deliver it to them. So I don't agree with all that rubbish, but that's just a personal opinion, so please don't sack me or anything like that. So recently, as I said, we've brought in these new a new way of measuring time and that, and there actually one very positive step is to reduce the 8 minutes to 7 minutes, which I think is a really good step. So we are going in the right direction to try and match performance to how we manage cardiac arrest. So that is a good thing. The press have a different view. To get to some quicker means you're going to get to others later. And so the press always go on a different angle. So this is what's appearing in the press in the UK. Heart attacks will wait longer for ambulances. You can dial 999 and be Skyped just to check that you are dead. So the newspapers love spinning it. Now this sells newspapers, but it's not useful if we want to improve survival from cardiac arrest. We need the national press on our side. We need to see the newspapers saying everyone should learn CPR. Let's start a campaign to teach CPR. So we should start using the press on our side rather than having a negative approach all the time. Now this is important, and I think it's very important, because you're going to hear a lot of data and people often give you all the survival like I've done already. So this is once again national data, and this is the first presenting rhythm when pads are applied to a patient in an out-of-hospital cardiac arrest. And you will see that the VF-VT group, the shockable patients where an AED will hopefully work or where EMS can get the best survivors, is about 25% of patients. So we are seeing, certainly nationally and I believe internationally, a slight decline in the number of patients whose first presenting rhythm is shockable. It's no surprise in out-of-hospital cardiac arrests that you see the majority asystolic. And in the UK, survival from asystole is generally less than 1%, because in most cases it's a terminal event. And if it is a terminal event, if it is someone's time to die, then we should make that as peaceful as possible. That's a different story. But we also have this scenario of pulseless electrical activity. And I won't go into all the ins and outs of pulseless electrical activity, but it's really interesting that we're only seeing about a quarter of cardiac arrests in a shockable rhythm. So yes, we should improve the survival for that group, but we can't forget the other 20% that are non-shockable. What are we going to do with those? And they require aggressive management as well. And I'll talk a little bit more towards the end about what we're trying to do about that group. So I think, yes, we must improve survival from ventricular fibrillation. That is a given. We must do that, but we mustn't forget the other groups of patients that are also in cardiac arrest and require aggressive care. So I said to you I would show you the national picture. You may just be able to see the ambulance services. I've tended to put the colour down a little bit so that you couldn't really read it that well. What you want to look at, essentially, to start with, are the green bars. The green bars are the ROSC, and they're the ROSC, the return of spontaneous circulation for patients in a shockable rhythm. So you can see that it's hitting 40 and 50%. So we are achieving a reasonably good return of spontaneous circulation out of hospital. In the UK, when we talk about ROSC, ROSC is defined as sustained ROSC, i.e. the paramedics achieve ROSC in the field and that ROSC is maintained until delivery to hospital. That is our definition in the UK. So ambulance services are doing well at ROSC. Okay? The survival is the red line, that's the overall survival. The purple line, which is the other interesting line to look at, is the survival from the shockable patients. So you can see it's very variable. So in London, just out of interest, we report ROSC and survival as an ambulance service, but we also report ROSC and survival by hospital. We also report ROSC and survival by commissioning group, so i.e. the government pockets. And that's quite interesting, because when we produce our reports, I will often get a call from the local commissioning group to say, why has that hospital got a 2% survival when the hospital 5 miles down the road has got a 20% survival? And then I meet the commissioners and ask that they may wish to look at the hospitals rather than the ambulance service. Because if we're delivering 50% ROSC to both hospitals, of course there's going to be patient differences, I accept all that. But nevertheless, I should be able to take a patient to a designated hospital where that patient will receive the same care as they would in a hospital 5 miles down the road, assuming the services are the same, because hospitals do vary. But it's very important. So this is national data that's reported monthly, looked at yearly, etc., etc. And you can see ROSC is fairly good. Survival does go up and down. The red line, just to be clear, the red line is everybody. So that's children, road accidents, suicides, etc. That will always be lower because the cause of the cardiac arrest is very, very different. We have to learn from the real world. Okay, I could stand here and show you lovely pictures of how to teach, but we have to learn from the real world. It should be mandatory. It should be mandatory that every time a defibrillator is used, the defibrillator is downloaded and the information analysed and feedback given to the staff involved in that resuscitation. So these are real downloads from real cardiac arrests. And if you look at the bottom box on the left where you can see the green markers, that is chest compressions at about 190 a minute. I'm trying to find that person because they must be an extraordinary individual to maintain a compression rate of 190. So it's important that we learn how to improve from real-world data. This is a very depressing one. This is from an ambulance service. It's not London. This is a real cardiac arrest where there is a 32-second pause with no chest compressions. You will not achieve survivor in that group. The only way you're going to know there was a 32-second pause is to look at the download and review the data. That's the only way you're going to do it. Because if you were to say to the paramedics involved in the resus, how did that resus go? The chances are they would say, it was all right actually, yeah, we got the line in, we got the tube in, we defibbed, we gave all the drugs, yeah, we gave all the adrenaline every 2 minutes. It's only when you look at the download that you found there were gaps in staying on the chest. So I plead to you that if there's one thing you want to do to measure is make sure that you're downloading your defibrillators once they've been used, and importantly feed back to the staff in a very non-threatening, positive way, because people need to learn. People need to learn, and you can only learn from real-world data. This is a study conducted in 2005 and involved London Ambulance Service, so we're one of the ambulance services involved. And this supports the use of download because this is data from London, but also 2 other ambulance services around Europe, where we connected some computers to the defibrillators so we could measure the quality of the resuscitation. And when I read this, I get a little bit sad. As I say, it's 2005. Things have improved since then. But it just shows you if you don't measure, you don't know. And that's one big message that everybody has to take away. I showed you this slide earlier on, published in the BMJ, where they said about stop taking patients to hospital, and then someone else said, not sure about that. There's a bit in that statement that I think is very important, and it says the best possible care at scene. So if we are going to respond to cardiac arrests, if we are going to improve survival, we've got to be able to provide the best standard of care. So we've got to be able to measure that. So the best care possible has to be measured. So this is London data. So this is the latest data I can tell you. I can't tell you the latest survival because we're still waiting for some outcomes, but I can tell you, so this is 16-17 data. This is fairly hot off the press. In fact, my CEO hasn't even seen this. So Steve, who's from London, please don't tell anyone. So last year we went to 10,525 cardiac arrests. That's up by 4%. Okay. As I said to you, we attempt resuscitation on almost half, so that you have to take half of this number out for the actual active resuscitations. There's no surprise there in London data from the national data in the fact that you have more men than women suffering cardiac arrest, the unwitnessed, the LAS witnessed, i.e. EMS witnessed, and bystander CP witnessed. You can see our response time, so from 999 call to arrival at scene is 7 minutes 39 seconds. We measure it down to the last second, and that's 8 seconds quicker than last year. It's really interesting how we do it. 999 call to EMS defibrillation is 11 minutes 17. Everyone goes, that's a long while. Well, don't forget, you've got to interrogate the call, you've got to drive there. In central London, traffic is an absolute nightmare. That's why we have motorbikes and push bikes in central London. And also often we've got large residential areas where you've got to go up to the 14th floor or the 15th floor. So there will always be a lag time. There will be. Does it need to improve? Yes, of course, but it's very hard to achieve. So this is the latest data. What we also do is each month we send out this to all our staff. So whilst we submit data monthly to the government, because that's a requirement, and also to the University of Warwick, we also try and keep all our own staff updated, because we have to make sure that staff are buying into this. We've got 5,000 front staff working in London, so we've got to get 5,000 staff buying into survival from cardiac arrest. So each month we send out this infographic which gives them all bits of information, and we try and do it in an infographic way rather than in a report, because most people will put the report down in the station table, go out on a call and never pick that report up again. So we do it in an infographic way, so hopefully, and this is month by month to keep everybody up to date. London, probably like Australia, is split into areas, so each area also gets their little report, and that's useful for the managers of those areas because everyone wants to be the best. No one wants to be the worst. So you end up with a little bit of rivalry, which is good in some ways. So we produce monthly data in the form of a cardiac arrest pack, and it's infographic like this. We do the same for heart attacks, i.e. STEMIs. We do the same for stroke, and we do the same for major trauma because we have to report those. So we do all that each month service-wide. Resuscitating patients and achieving ROSC, if you can increase your ROSC, so this is London data, you should be able to see an increase in survival. So as I said to you, our survival is hitting about 31% for shockable rhythms. For all comers, our survival in London is hitting at the moment about 9%, so that's everybody. So you can see we've been collecting data accurately, or fairly accurately, since 2001, and it's taken us years to start increasing survival. So when you adopt the 10 steps, when you follow the Academy mantra, it doesn't happen overnight. This is a long-hauled journey that you have to go on, and it takes years. And there will always be blips in survival. There will always be blips, and you have to accept that, okay? But providing we start to see the right direction, you know that you're starting to get things right. We introduce in London checklists. We use a cardiac arrest checklist. It's interesting trying to devise a checklist about what to put on it. To develop this checklist took us over a year, and everyone goes, over a year? All you had to do was write a few things in each column on a sheet of paper. You'll notice it's very nice colours. The reason it's nice colours is we consulted the aviation industry to identify the best colours to look at that are nice to see. So this cardiac arrest checklist has taken years to develop. And staff like it. We personal issue as a plastic card. We need to update it, of course, but this is a way of just making sure that you're getting the key things right. And we put that inside our paramedic drug bag, so when you open the bag to give the adrenaline, the checklist is in front of you, but you've also got one in your pocket, and they also put one in their paramedic bag. Why am I saying all that? A lot of resuscitation, so if you were to talk to any paramedic and say, what do you do to VF? They will all say, shock it. What do you do? How do you manage an airway? Well, we intubate, or we put a supraglottic device in. So everyone knows the components. But what we are not so good at teaching is the CRM, the human factors element, the stress, how people cope with a paediatric cardiac arrest. So I think we need to do more work about the human factors relating to the resuscitation. And that's a lot of work to do, because teaching human factors is actually very, very difficult. I think once you do get ROSC, there needs to be appropriate management and appropriate destination. What do I mean by that? Back in 2006 in London, we used to have targets about giving thrombolysis for myocardial infarction. It was called the door-to-needle time. And we were measured on the door-to-needle time, because the faster you got your drug, if you were having a heart attack, the better it was. I decided we were not going to measure the door-to-needle time. In fact, I decided that we were not going to allow our paramedics to give thrombolysis. I decided to do something different. I went to some friends that I knew from the hospital days, i.e. the cardiologists, and I said to the cardiologists, what's the best treatment for a heart attack? And they said, well, do an angiogram, put them on the cath lab table and have a look at their coronary arteries and see what you can do. So in 2006, we set up what are now called HACs, heart attack centres. We have 8 heart attack centres in London. They are 24/7. They are not allowed to close. We do not allow them to close, and we do not have a conversation with them when we're taking them a patient. i.e., once we've decided we're going to take a patient, we tell them we're coming. It is a non-refusal policy, so they cannot refuse the patient. And then we just take the patient. Why am I telling you that? Well, that was in 2006. An extension to that was not all patients that having a heart attack have a classic ECG like the one you can see here. Some of the heart traces are going to be different. So we now extend it to include patients that have ischemic ECGs. They also go to the cath lab on a non-refusal policy. And the next extension, which we introduced a few years ago, is the emergency arrhythmia pathway. So if a paramedic picks up a patient with certain abnormal cardiac rhythms, they can access dedicated arrhythmia hospitals, bypassing the emergency department straight to an electrophysiologist. I believe that's the first in the world. So why am I telling you all that? Well, for out-of-hospital cardiac arrest, you probably have either had an acute cardiac event or an acute cerebral event, unless it's obvious trauma, suicide, overdose. So when someone suffers sudden cardiac or sudden death, it's either sudden cardiac death or an acute neurological event. So we started talking to the centres about you need to take cardiac arrest patients. So we are working towards moving away from heart attack centres to cardiac arrest centres. That's got to be the way forward, because the patient's going to need an angiogram at some point, and they're likely to need a CT scan at some point. So that means that we bypass hospitals, and we do that quite frequently anyway, and it's easy. It's slightly easier for us in London because geographically it's very easy. But it's important that we take the patient to the right destination. This particular case, just very briefly, I was on duty for Kate and William's wedding that you may know about, and I was parked in a car, in a response car not far from Buckingham Palace. Not that I would ever get to Buckingham Palace, when I was called to a cardiac arrest in an area of London known as Piccadilly, which is a very busy area. I got it as a cardiac arrest. When I arrived, the police were doing CPR. I arrived within, it was less than a minute because I was parked just at the top of the road. And it was a taxi driver, one of the London black cab taxi drivers, who had driven into the back of a police car. So the police got out, because they were unhappy, to find the taxi driver in cardiac arrest. Okay. He received a shock, as you can see. He got a rhythm very quickly. The 12 lead underneath clearly shows that he's having a heart attack. He's taken to a dedicated heart attack centre, unconscious, and for the clinical people in the audience, with a GCS of 3, because that's also important. We do not discriminate against the patient having a GCS of 3. They're still going to the heart attack centres. This chap went home 2 days later. If I'd have gone back a year, he would have been dead. So we have to look at the whole model. It's not just what EMS does, it's what everybody does, including the hospitals. I'm telling you that because this is the latest data from London, and I would draw your attention to survival to discharge. So for this specific group of patients, so these are patients who have had an out-of-hospital cardiac arrest. They've been resuscitated by EMS, i.e. ROSC is achieved, and they are taken to a heart attack centre. That group of patients, albeit small, that group of patients have over a 50% survival because we're treating the underlying cause. So I would say to everybody, there are subsets of patients that need to be managed differently. We have to accept that. But what we do know is that if you have a cardiac arrest and you have a blocked coronary artery, which is often the cause of the cardiac arrest, you need to be in an appropriate hospital. And you can achieve excellent results. And this is not just VF. This is a cardiac arrest that might be asystolic or might have presented in pulseless electrical activity. So this 50.7 is all comers. And that is an exceptionally good survival for that small group of patients, but important group of patients. As time goes on, we're going to increase the number of patients that we convey to these centres. It was mentioned when I was introduced about our advanced paramedics. Cardiac arrest, if you look, and I think Australia have published data on it as well, if you look at all paramedics, they probably see 2, 3, 4, maybe 5 cardiac arrests a year. And when they do see a cardiac arrest, we expect them to be at the top of their game every time. That's hard. So what we decided to do in London, with Jason Killings, who some of you will know, who's the Director of Ops for London Ambulance Service, we decided to introduce what we call advanced paramedics in critical care. We can distinguish them differently from everybody else because they wear red epaulets. We put one in the control room to look for the patients and dispatch the advanced paramedic. It's a pan-London service. We only have 4 of them on duty at any one time. They're car-based. They have to have done at least 5 years as a paramedic on the road, and they're all degree educated. We train them for about 6 to 7 weeks in critical care. They're already trained to paramedic level. We take them to a next level. That includes ultrasound. That includes thoracostomies. That includes surgical airways. We train them to an exceptionally high level. We look after them in the sense we provide a lot of support for them on a one-to-one basis. Why am I telling you that? Interestingly, if you look at the cardiac arrests they attend, you see an increase in survival and you see an increase in ROSC. So when we done a snapshot audit of the critical care advanced paramedics, they were achieving ROSC in 34% compared to 29.9%, as you can see. We saw survival of 11.3% all-comers versus 9% all-comers. So they are contributing something to improving survival for cardiac arrest. We suspect a lot of what they're doing is based around the human factor element of arriving and getting everyone sorted out into their roles and getting it all under control. It's not just all the sexy stuff. But I can tell you that ultrasound is absolutely essential in patients who are in a non-shockable rhythm. Because without doing ultrasound in patients in a non-shockable rhythm, you are virtually working in the dark. You don't know what you're doing because you can't see the heart. And we can talk about that outside if you want to. The advantage of having a group of specialist paramedics that attend cardiac arrests, just to give you some idea, when they're on duty on day shifts, they do 4 days at a time, so Monday, Tuesday, Wednesday, Thursday day shifts, they would see about 10 cardiac arrests as an individual. So they're seeing about 10 cardiac arrests a week. That's why they are very slick. So the advantage of having a group like that is we can do research. And research is important if you want to continue to move forward. We've just published a paper on double sequential defibrillation. That's where you use 2 defibrillators to shock the patient, not 1. Okay. It's fairly impressive. It gets them out of VF. And we do use mechanical devices. I'm not going to go into the ins and outs of mechanical devices, but we have our own unique checklist on how to use a mechanical device. We are the biggest user of a mechanical device, the biggest user. We don't have the biggest number of devices, but we are the biggest user. Each of the advanced paramedics in a 20-month period used a mechanical device roughly 183 times each. So having this group allows us to do research to move the program forward as an entire EMS system to improve survival. I said to you about taking patients to specialist centres. We are currently just received a grant of just over £1 million for something called the ARREST trial. And this started off with about taking patients to the cath lab in cardiac arrest. And I know there's parts of Australia where you're doing this already. So this is a patient taken to the cath lab in cardiac arrest, which for EMS is actually quite difficult to do, because you've got to move the patient to the vehicle and then drive. That is not easy. That is not in any guidelines. Okay, that's difficult. And this is the same patient who gets successful angiography, successful stenting, and ultimately gets discharged. And we're about to go live with the ARREST trial in the next couple of months for the whole of London. So it'd be interesting to see what it shows and tells us. More recently, so bringing you back to the national picture, more recently a document has just been published called Resuscitation to Recovery. It's about a national framework to improve out-of-hospital cardiac arrest. It's endorsed by almost everybody you can conceive, and is supported by everybody, including hospitals, i.e. the Intensive Care Society, etc., etc. So cardiologists are involved with this, emergency physicians, and I'm happy to email a copy of this to anybody that wants a copy of it. But this is an important document to use to set the framework of how you're going to improve. And this is essentially based around the chain of survival and how we improve care. And so it talks about all the elements. So it's an important document to use, and it also talks about cardiac arrest centres. And then, as I come to the end, the Association of Ambulance Chief Executives, which I think is very similar to CAA, if I'm not mistaken, all the cardiac leads from the 10 ambulance services, so all the consultant paramedics that are involved in resuscitation, meet together once a year where we discuss cardiac care within the UK ambulance services, and we have a set of statements. We call them the statements of best clinical practice, and then each consultant paramedic takes that back to their ambulance services to meet with their operational colleagues, to meet with their chief executives, to start saying, we're all deciding we're going to do this. So one of the important things, we've heard about telephone CPR. If you're going to do telephone CPR, you need to measure the time it takes you to identify cardiac arrest over the telephone, but you also need to measure the time of first chest compressions from identifying it on the telephone. So from identifying cardiac arrest from the emergency call, how long does it take to get the first chest compressions underway? And so these statements, we can't mandate them because each ambulance service can run their ambulance service how they wish within a framework, but that's why we call them statements of best clinical practice. So, thank you for listening to me. There's lots more to do. Data is absolutely essential. We should make defibrillation download mandatory. My view is we need to look for out-of-hospital guidelines based on the guidelines, but taking into account that out-of-hospital is different, and we must continue to do research to improve survival. Thank you very much for listening.